Is it possible to end AIDS as a public health threat by 2030? The United Nations thinks so, and the guests on this podcast series certainly hope so. But it's going to take effort, innovation, connections and funding, which we are going to explore over the next 6 episodes. Welcome to Can We End Epidemics? A podcast series by the global biopharma ViiV Healthcare in association with its majority shareholder GSK and developed by FP Studios. I'm Henry Bonsu. The theme for last year's World AIDS Day was Let Communities Lead. And so that is where we start today. Joining us are Anwar, who describes himself as a grassroots trans activist of French and Moroccan heritage. He is the movement building lead at Global Action on Trans Equality, or GATE. And Dr. Nneka Nwokolo, who is Global Head of Patient Engagement at ViiV. She's also an honorary consultant physician in HIV and sexual health at Chelsea and Westminster Hospital in London. Welcome, Anwar, and welcome, Dr. Nneka.
Thank you very much.
Thank you so much for the invitation.
Now, Dr. Nneka, let's start with a bit of perspective. Some stats, it would help. Around 39 million people around the world were living with HIV in 2022. And during the same year, 630,000 people died from AIDS-related illnesses, and 29.8 million people were accessing antiretroviral therapy. Now, 51.3 million people have died from AIDS-related illnesses since the start of the epidemic. Now, Dr. Nneka, when you hear those figures from UNAIDS, which is the lead United Nations body which is trying to eradicate AIDS by 2030, how possible do you believe it is to achieve that goal, to actually eradicate AIDS by 2030?
I think the UNAIDS goal is admirable and very optimistic, but I think that without political will, without global political will, and without addressing the stigma that exists still for people living with HIV, I think it'll be a huge challenge. I talk about political will because it's clear that in countries where there is political will, we're quite far down the journey to eradicating AIDS in those countries, with the majority of people having access to testing and treatment and having suppressed viral loads. But we know that there are many people who live in countries around the world where there isn't the political will to encourage access to treatment. The other issue about stigma is certain communities around the world are very stigmatized. HIV is a stigmatizing condition. And as long as stigma and discrimination exists, they, I think, will prevent people from coming forward to access testing and treatment. And there are countries in which being from the lesbian, gay, bisexual, transgender, and intersex communities are highly stigmatized and criminalized. And as long as this continues to exist, I don't see how you can end HIV or AIDS, because, again, this will prevent people from coming forward to access care.
So political will and stigma. Let's develop some of those points by turning to you, Anwar, from the Global Action on Trans Equality. Now, you've got a tremendous background, particularly when it comes to grassroots and community organisation. You've worked in the feminist, trans, decolonisation and social justice movement for over 15 years. How do you respond when I read out those figures, that colossal toll, but also the very large number of people who can now access antiretroviral therapy?
Thank you so much. I fully agree with everything Nneka just said, and to this idea of 2030 eradication, is it possible? Again, I really salute the kind of effort and ambition there, but as my colleague just said, we are far from there just because we're not investing the time, the effort, the money that we should into the communities and their needs and priority. And what does that mean to invest into communities, right? It means, of course, to put the money and the effort into understanding the people's needs, priorities, and challenges. But it also means giving people the means to be their own leader and to pave their own way and to decide on their own terms how to fight against HIV/AIDS. I also want to add on the list stigma and discrimination, criminalization, and not only criminalization of HIV status, but criminalization of transgender identities, criminalization of sex work, criminalization of drug use. So, when I hear those numbers, I'm not surprised at all. I'm not surprised that in certain contexts where those social, political, and legal enablers are considered properly, we do see some great progress, but we're still far beyond any targets that we are setting to ourselves because we are really failing in understanding and in enabling communities to lead their own approaches.
Yeah, well, as if to underline what you've both said, I can refer to Winnie Byanyima, who's the executive director of UNAIDS, who recently said that if we don't promote the inclusion of all people and seek out the millions who are not yet on HIV treatment, we will not reach the 2030 goal. And as if to illustrate this, I can refer you to some of the statistics from UNAIDS. If you consider the HIV prevalence rate among the adult population in general, let's say age between 15 and 49, it's 0.7%. So less than one person in 100 has HIV. But when you get to some of the populations you've both referred to, it's so much higher. So 2.5% among sex workers, 7.5% among gay men and other men who have sex with men, 5% among people who inject drugs, 10.3% among transgender persons, and 1.4% among people in prisons. So, how do we reach those underserved, those marginalized groups of people? What is the most successful way of delivering the message and delivering the help and the treatment? Anwar, what do you think?
I'm going to be a bit of the broken record here. For me, it's always go back to community-led approaches and community-led approaches that are actually financially, politically, legally, socially enabled. And I completely welcome, of course, the notion of key population that has, the idea that certain groups face higher risk of HIV infection due to various kind of social, legal, behavioral factors. That's, a great success because it has helped us targeting intervention in a much more successful and efficient way. However, what I see happening a lot across those 5 key populations that you just named is that we are still lacking understanding of the cross-cutting kind of lived realities between these key populations, that we tend to think sex workers as if there were no trans people that engage in sex work. We tend to understand trans people as if no one was injecting drugs or, living in closed setting or in prison. So for me, I see also a big priority in understanding the kind of like cross-setting and intersectional nature of these lived realities and how a trans sex worker will be particularly at risk for all the reasons mentioned, for instance.
But Anwar, so if one takes account of that cross-cutting or intersectionality, what kind of difference does it make to the approach? What kind of difference does it make to the outcome?
Because once you understand how these systems of criminalization of violence kind of intersects, you're better able to tailor approaches and tools and programming that are actually informed by the needs and priorities of these communities. And that's again why community-led approaches are so important, because most of non-community-led approaches are completely failing understanding the complexity and the tangled nature of the violence that people are facing. I can give you an example, for instance. Okay, when we look at a trans sex worker, I would say anyway, being a trans person is, if not criminalized, at least you're heavily discriminated against, right? On the job market, in school. So it means that you're completely going to be excluded from the economic system. In this context, sex work appears to be most of the time one of the only sustainable way to survive economically. If you add to that increasing and harsh criminalization of sex work, you end up with people literally battling against structural transphobia on the one hand and sex work criminalization on the other hand. And there is no way that those people who are in complete survival mode, there are no way that those people have the time, the money, the capacity, the mental ability to even think HIV prevention and treatment. So if we fail understanding the particular condition of trans sex workers, we are completely failing this whole population that is actually showing high level of prevalence when it comes to HIV.
All right. Dr. Nneka, as Global Head of Patient Engagement at ViiV Healthcare, what do you understand by this kind of outreach, the intersectionality that Anwar was discussing? Because I'm wondering whether your understanding of it matches up with Anwar's understanding of it, because you've got a big pharma organization, but a grassroots community organizer. Do the two of you meet?
Absolutely. We have to meet. And I agree completely with what Anwar has said. And part of my role as head of patient engagement at ViiV is really how we think about how we engage with communities. And the thing that's most important to me is that we go out into the community and that we engage with community leaders. You know, there is this concept of hard to reach. There is no such thing as hard to reach. We are hard to reach. We who work in healthcare, we who work in healthcare organizations do not make it easy for communities and the people that we want to serve to reach us. But the people who know these communities and these individuals best are the community. People like Anwar, community leaders. And so it's really important that we engage with them to understand what the challenges are and to support them, and also for them to support us to reach these individuals who Anwar has described so eloquently and who I believe that we are failing. And so partnership is crucial. And without involving communities, we can never, ever solve this problem. And I think we saw this in COVID. You know, communities that were engaged were able to do much better than people who were isolated. And, you know, when you think about it, it makes sense that the people who are affected by an epidemic should be the ones that we involve to try to address it.
Okay, but what does that involvement look like, Dr. Nneka? Because people often talk about partnership and engagement, inclusion, but you still often get those who are at the grassroots, who are connecting on a one-to-one or a peer level with people who are the most marginalized and most vulnerable and most at risk, and saying we haven't got the funding, it's not sustainable, we have to jump through hoops. There's such a difficult route to actually access you big guys, whether you're in farmer organizations or in government or at NGOs or UNAIDS. So what is the best route to you for Anwar and the people Anwar is working with?
Well, I think, first of all, there has to be will. You know, we've talked about political will, but there has to be the will of everybody who is able to play a part in this. And it has to be meaningful. It mustn't just be lip service. And so I think, first of all, it starts with conversations, with honest, open conversations about what is needed, but also about what's possible. Because sometimes expectations may be potentially unrealistic for lots of different reasons, but it's important to be open and clear about those things. But I think most of all, there has to be a true commitment that is more than just lip service. And then there is the need to work together to try to find solutions and for it not to be one-sided.
Right. And Anwar, can you give us examples of successful collaborations between some of the organizations you work with and some of the bigger organizations, whether it's the drug companies or organizations at the UN level or EU level, that people can understand and think, okay, that's how that worked. Maybe I can try that approach, because in the end, it's about delivering services to people.
Definitely. I mean, there are tons that also kind of illustrate how much expertise there are in our communities. The most successful initiatives I've seen are directly engaging with community members. I don't mean like an afterthought, or I don't mean like kind of dropping a report at the end and saying, are you happy with it? I mean with engaging with local leaders and community members from the very early stage of planification. And that goes for HIV, but that goes actually for any kind of like national medical guidelines or protocol. What we see when we talk about transgender people is that there is a direct correlation between the access to gender affirming care and the uptake on HIV. So what you see is that when you develop tailored, culturally and clinically sensitive and trans-adapted guidelines or protocols, whatever it is, that have been thought by and for community members, you're going to have a much higher rate of success that is going to enable people to, again, disconnect with this survival mode and be way, way better able to both be cared for and care for themselves. So I feel like whenever there are nationally led guideline protocols at nationally, but actually at any level, whenever you engage with community members from the early stages, that's where you see actual success.
Uh-huh. And Dr. Nneka, earlier when I read out my list of 5 vulnerable categories, I talked as though it was comprehensive. But there will be people who, despite all the outreach, all the work that groups and governments and entities have done over the past 45 or so years, groups that will still be left out, groups that will be an afterthought, groups that are almost invisible. How concerned are you about that? And which groups would you identify?
I can think of two groups, and there are others. The first group that I think about are men, and this refers both to heterosexual men but also to trans men. The reason I call out heterosexual men is because when you think about all the initiatives that are being addressed towards populations who people perceive as being most affected by HIV, there's very little that you can see that goes to address heterosexual men. But for example, when you think about adolescent girls and young women who are among the most impacted by HIV, they don't acquire HIV from the air. They acquire it generally from heterosexual men. But these men appear to be excluded from HIV campaigns and so on. And it's true that when you look at the burden of HIV, it's not as high in heterosexual men because it's easier for women to acquire HIV than for men. If you exclude them, then it means that they are not involved in prevention campaigns. And men have a lot of power over women. So, for example, if a woman is going to access care, she very often needs the permission of her partner. And so if he says, no, you cannot
I suppose
go.
that depends on what part of the world, and this is useful that you said that,
Yes.
because of course there are some parts of the world, particularly in Western Europe, in like the likes of Japan, Korea, USA, etc., where women have a lot of agency in that area. And then when you look at the global south, women have a lot of agency in other areas. So can you define it a bit more closely?
Okay, I will. So there are some communities in different parts of the world where just in generally, with regard to sexual and reproductive health, women don't have a lot of agency. And this may be because of cultural issues, it may be because of issues of finance. But even in countries where women do, so in the global north, where women do have overall a lot of agency, there are communities within those countries where women don't. And you often don't see those women. But the point I'm trying to make is that in such communities, if men are not engaged, if men see themselves as being excluded, then they are less likely, I think, to participate in initiatives to reduce the risk of HIV acquisition for women. And so it's really important to take men along, even if they are not the primary group that you are concerned about with regard to the risk of transmission.
I'm wondering, Dr. Nneka, how that message would be tailored, because I remember the early campaigns of the 80s, the Tombstone. This is in the UK specifically, but there may have been parallel campaigns around the world. And it said, "Don't die of ignorance." And it gave the impression that we were all equally at risk. And over time, it then was more defined. It was tailored towards the community of men who had sex with men, women, particularly in sub-Saharan Africa. And it was felt that other people were not really at risk. And that is almost how it's continued. So how would one almost roll back on that and say, hey, men, this is still an issue for you, straight men?
Yes, and this is really important. And I think that the idea that HIV only impacts certain groups of people has been a significant cause of damage, of concern. Because the reality is that HIV can impact anyone. We know that there are some groups of people who bear the burden of it much more than others, but we know, and I know as a doctor, many, many people from groups that people don't consider necessarily to be impacted by HIV who are living with HIV. You know, an example, for example, is heterosexual white women. No one thinks of a heterosexual white woman as being somebody who might be living with HIV. I have many patients who are heterosexual white women. So the idea that is in society that HIV affects certain groups of people needs to be removed. And I think everyone needs to understand that HIV can affect anybody. And I think that's where we need to start. And I think this is where we need governments, and we need to have campaigns that work and that are sensitive, but that are realistic and not sort of scaremongering, that show people that actually everybody potentially can acquire HIV. And these are the things that it's important to be aware of with regard to how it's transmitted. But importantly, they need to address the stigma that exists that prevents people from coming forward.
Right. Okay. There's a term called Ubuntu from Southern Africa. I am because you are. And I think, Nneka, you've also talked about something called U equals U.
Yes. Yeah. So U equals U stands for undetectable equals untransmissible. And it's the concept, not even the idea, the fact that a person living with HIV on effective treatment and who has an undetectable viral load, so whose virus is suppressed to levels that it can't be detected by the test, is incapable of transmitting HIV to sexual partners. This is a scientific fact. It has been shown in many, many studies. And for me, this is one of the most important ways to start to address the stigma associated with HIV, because there are still a lot of people in the general population who fear people living with HIV. There's never been any reason to fear people living with HIV, but people do. And one of the main reasons that people have this fear is because of the fear of acquiring HIV. But we know now very clearly that if a person is on treatment and virally suppressed, it's impossible to transmit HIV. And so knowing that means that people living with HIV should be able to expect to be in relationships with people without HIV and to have normal sexual relationships in the way that people in the general population can.
All right. Anwar, let's deal with that issue of stigma and look at the correct approach to try to support those living with stigma, to educate those who might visit stigma on others. Can you talk about some of the work you've done and which areas of the world, which countries perhaps you feel the problem of stigma most urgently needs addressing? Because in some parts of the world, the stigma is far less than in others.
I love what you just said about destigmatization being a central pillar of whatever we want to do if we want to eradicate by 2030. I think one extremely interesting approach that we've seen is approaches or strategic communication that are more centering pleasure, like really pleasure-centered messaging that kind of takes the lens away from the stigma. And I think you were sharing earlier, how can we get the typical cis-straight man, especially I would say white in global north, how we can get this person still understand that HIV is something he should be concerning with, is once we have addressed stigmatization. No one wants to feel concerned by HIV given how heavily stigmatized it is. So for me, having an approach that is actually centering pleasure, that is centering holistic wellness, that is centering sexual health and reproductive rights as a fundamental right, is something that kind of like divert a bit this idea that living with HIV is a terrible burden that we should be ashamed of. So for me, that's a first approach. And then about your question about countries, I have to say that I'm, I guess, on purpose going to kind of not directly answer this question, because there is a clear colonial approach to what are the countries that are facing the HIV burden more than others. Of course, it translates into numbers, but it nurtures this idea that certain countries would be kind of models when it comes to HIV, and other would be kind of the bad pupils in the room. I think
that's not what I'm trying to suggest,
No,
Anwar.
of course.
What I'm thinking, though, is that if, say, for example, in South Africa, where the disease burden some years ago was extremely high and it was leading the news in many parts of the world for quite some time, but because of concerted action from a range of stakeholders, including government, and people ending the denial that causes so much stigma, so much shame, and so much death, they were able to push for generic drugs, push for the kinds of things that people would take for granted in the global north, in Europe, for example, but that Africans in particular were excluded from. And if it worked in South Africa, perhaps some of the countries in the neighborhood and elsewhere might say, okay, well, we could try that too.
Mm-hmm. Sorry, I wasn't assuming that that's what you were implying. What I was heading to, though, is to say, again, this idea that we're nurturing a bit an idea that there is, global south, global north. And what I wanted to point at is even in let's say, like high-level income countries or global north, actually you have subpopulations. And the further marginalized from those countries are also heavily impacted by HIV. And I'm going to give an example. Asylum seekers, refugees, and migrants from global south, almost forced migration to a certain extent. What we see is that there is, of course, a high prevalence among this population in countries such as France, UK, Germany, Western Europe, let's say. There is a high prevalence of HIV. What we see, though, is that most of those people are not coming with HIV. They contract HIV once they arrive, and it shows what are the conditions of such people arriving in global north. So I just want to kind of challenge this idea that because it is widespread, I also happen to do a lot of grassroots and kind of training work with social workers, with medical healthcare providers. And it's a constant battle to debunk the myth that, migrant and refugee would be spreading HIV. Actually, they contract HIV here, where I'm based here right now, for instance, in Paris, France, because of the condition we welcome these people in. So I feel like we do need to have a holistic and global lens to it, because otherwise we're completely failing understanding what are the roots and the dynamics behind the scenes.
Mm-hmm. And Dr. Nneka, let's push back a second. We rarely hear about HIV and AIDS on the mainstream news in most countries these days, particularly since the rise of other diseases like the SARS and MERS and the renewed focus on neglected tropical diseases, and then of course the prevalence of malaria, and then of course in the last 3 years COVID. So against that background, why is ending the AIDS epidemic so significant today? A lot of people think, well, it's no longer a life-threatening disease for most people, they think. It is a disease that one can treat and one can live a natural lifespan with. So why this target of ending it by 2030? Why should people who don't really see it as a problem anymore care as much as they did?
I think there are a couple of reasons. I mean, the first is that untreated HIV remains a devastating condition. Yes, when you think about it on a sort of global scale, it may be less important in terms of numbers when you compare it to some conditions, but it is a devastating condition. And although many people have access to treatment, in many countries there is not access to treatment, and so people are still dying. And as long as people don't have access to treatment, then there will continue to be the risk of transmission. And although transmission has fallen to fairly low levels now globally, when you compare them to before, the reality is that as long as those people are unable to access treatment, if they have HIV, there will be the continued risk of transmission. But the other reason, and to me probably the most important reason, is because it carries a stigma unlike many, many other diseases. And it is this stigma that actually is what will kill people even in the presence of effective treatment, because it is this stigma that will prevent people who may have access to treatment in the beginning from potentially continuing to access treatment if when they go to hospital they experience healthcare related stigma, which is a big thing. I mean, people, when you talk to them, will often say that the worst stigma that they have ever confronted has been in healthcare, has been from the people who are supposed to be providing them with care. And so as long as environments like this continue, we will never get rid of HIV. And if you can't get rid of it, then infection rates will continue and will rise.
Let's end this discussion by focusing on success, because if you look at the figures I read out earlier, although AIDS has exacted a terrible toll on people worldwide over the last 40 or so years, at the same time, millions of people are now living, we hope, fulfilled lives, and hopefully natural lifespan as a result of medical intervention, as a result of outreach, community organization, and partnerships. So I'm wondering, Anwar, what success would look like to you?
For me, success looks like a future where community are really centered, and community in a holistic and empowering understanding. Communities have actually in their hands the means to make the changes they need. Where certain populations that are traditionally structurally left behind are actually, their voices are amplified and they are leading movement. You were referring very quickly earlier to trans men and trans masculine people in general, which are structurally overlooked. And we see an increase in understanding that this is a population that has its specific invisibilization, marginalization that we need to care for. So I would say that's what the future for me would look like, where these communities are centered. And how do we center communities? Of course, by giving financial, it's all about the money, like most of the time, financial and political mean. And this includes also typically enabling intermediary organizations such as the one I'm working for, Gay Global Action for Trans Equality, also giving the mean to those community-led organizations that are both doing community support and advocacy work, for us to actually have the mean to do the work we do. So for me, like, the future looks like a community that is empowered, enabled, and thriving, bottom line.
Dr. Nneka and Anwar, thank you very much indeed. You've been listening to Can We End Epidemics, a series of 6 episodes where we discuss disease prevention, the future of medicines and funding, healthcare, among other issues. Check out our show notes for a helpful glossary of words. I'm Henry Bonsu, and until next time, thanks very much for listening.